My name is David Conen. I'm a cardiologist and researcher from McMaster University at the Population Health Research Institute in Hamilton, Canada. I'm here this morning here in Amsterdam at the ESC to talk about our COP-IF trial, which stands for Colchicine for the prevention of atrial fibrillation in patients undergoing thoracic surgery. Previous studies have shown that cardiovascular complications in patients undergoing non-cardiac thoracic surgery is a major problem. For instance, perioperative atrial fibrillation has been described in approximately 10% of patients, and myocardial injury after non-cardiac surgery, which is myocardial injury due to ischemia to the heart, has been described in up to 20% of population. So far, there have been no safe treatments that can prevent those two complications, and therefore, the goal of this study was to try to find a medication that could prevent at least one of the two complications. Because prior studies have shown that AFib as well as myocardial injury are associated with high levels of inflammatory biomarkers, we thought that using an anti-inflammatory medication to treat these patients may be a good start to try to find such a medication. We therefore chose colchicine, which is an established medication to treat patients with gout, pericarditis, or other inflammatory disorders in clinical practice. We treated patients for 10 days with twice daily dosing, either the active colchicine 0.5 milligram or matching placebo. The total follow-up of the study was 2 weeks. The two main co-primary outcomes were clinically important perioperative atrial fibrillation and myocardial injury. There were several secondary outcomes. The safety outcomes were sepsis and infection and non-infectious diarrhea. We enrolled 3,209 patients across 11 countries in 4 continents in this truly international trial. We found that colchicine reduced the primary outcome of clinically important AF by a non-significant 15%. With a hazard ratio of 0.85, the p-value was 0.22. For the second co-primary outcome of MINS, or myocardial injury, we found that colchicine reduced the second co-primary outcome by 11%. Again, this reduction was not statistically significant with a p-value of 0.16. Secondary outcomes showed similar results of a non-significant reduction in multiple composites of ischemic complications after non-cardiac surgery. We found that colchicine increased the risk of non-infectious diarrhea, which has been shown in previous studies, by an absolute 6% increased risk. We also found that these diarrhea episodes were usually transient and benign, because the median length of stay in patients with diarrhea was not longer than in those without diarrhea, and there was only one hospital readmission for diarrhea in these patients. The second safety outcome of sepsis and infection was not significantly increased in patients taking colchicine. So I think that our study, although both co-primary outcomes were not significant, did show a very encouraging trend towards potential prevention of ischemic complications in patients undergoing non-cardiac thoracic surgery. I think these are important results because preventing these complications is a major unmet clinical need. And therefore, I think we will need additional studies, larger studies, that may be in somewhat different populations to try to tease out which patients truly benefit from colchicine. Our study is also very much in line with previous studies among patients with coronary disease. There were 2 major studies in the past called LODOCO-2 and COLCOT, which showed that colchicine reduced the risk of myocardial infarction or the cardiovascular events by about 20% in these patients. And although this is a very different patient population, I think our COP-IF trial results are in line with these results, and we hope that we can start soon additional studies that then may show a potential benefit of colchicine in patients undergoing surgery, which would be much needed. Thank you so much for having me.